Good afternoon, ladies and gentlemen. It's such a great pleasure being here, this wonderful city and a wonderful country. I would like to say thank you to Toshiba for the invitation. I look like Japanese, right? And some of you will say, so you're from Brazil? Yes, my DNA is 100% Japanese, but I'm born in Brazil, so I'm 100% Brazilian. So this is Brazil. It's a mix of different culture, and Brazil is the largest outside community of Japanese outside Japan, right? It's largest Japanese community. Just in São Paulo state is close to 2 million Japanese and living in Brazil. So today we'll talk about cardiac MRI. I will talk a little bit about our experience with the 1.5 Tesla and using the 32 cardiac coil and some of new features and new sequence. Just to let you know, this is our university. So we are about it's 6 hospitals close together, 2,200 bedrooms. Our department, we are working with 13 MRI scanners. We have a 1.5, we have a 3T, we have a 1.7 Tesla past 2 years ago, and last year we installed our first PET MR. We are working with 14 scanners, many all different types from Toshiba and other vendors, and we perform about 2,500 cardiac MRI and 4,000 cardiac CT per year. This is our institution. So this is the Cancer Center. This is the Heart Institute. This is the physician's office that is close here. There's about 500 physicians' office across the street. So this is our institute here, those two buildings. This is the medical school, the university. So this is our scanner, and this is the 32 cardiac coil. And I will talk about non-ischemic heart disease. I will not talk about ischemic heart disease, because I think in non-ischemic heart disease is where MRI can play a very important role, and I think it's the best exam to rule out a non-ischemic heart disease. For ischemic, we have a SPECT, we have a PET, we have a stress echo, and you will see in the next presentation. Also, CT now can play a very important role about the ischemic heart disease. But in the field of non-ischemic heart disease, MRI is the best exam. And we know that it's pretty simple. We have the cine MRI, like 2-chamber, 4-chamber, 3-chamber view. The inversion recovery sequence is a T1 and T2 weighted sequence, and also the delayed enhancement, where I think it's the gold. I mean, the key part of the exam is the delayed enhancement, where the other exams cannot give the same information. So just a quick review about the gadolinium. So gadolinium is intravascular and extracellular. But once you have a membrane rupture, like in acute myocardial infarction, so the gadolinium can get inside the cell, then this is delayed enhancement. So it get inside and the washout is delayed. And when we have a scar, also the gadolinium, the washout will be, there will be a delay. So this is what we call delayed enhancement in those two cases. So what is important to keep in mind is everything that is bright, so everything that is the delayed enhancement, so is dead or is bad. So like in the myocardial infarction here, so this is the fibrosis, this is the dead area, but it's also bad. It could not be dead, but it will be bad, like in amyloidosis, we know that is bad. Everything that is bright in delayed enhancement is bad, because we can see here that the mortality is significantly higher when we see late enhancement in the myocardium. So those are some very, the patterns of delayed enhancement. So the ischemic is always happen when there is the endocardial area involvement. So it's pretty easy to differentiate what is ischemic from what is non-ischemic. And what is non-ischemic is like here is the mid-wall and the endocardial border are preserved. So it could be also the epicardial, in the epicardial border for non-ischemic heart disease. So I will show many cases to not be that boring, because I know that maybe not the majority of you are doing cardiac MR, but so I will show cases because I know the radiologists really enjoy very good image and nice images. So this is a case of 61 years old with a dyspnea and chest pain, heart failure class 2. So moderate dysfunction by the echo. And what we can see here, there is diffuse hypokinesia. In the infralateral wall, there is almost akinesia or a severe hypokinesia. So this could be ischemic or not ischemic. So just from the cine, it's not possible to differentiate what is the reason for this. But when we do the late enhancement, so we can see that there is a diffuse mid-wall enhancement. So, and the endocardial border is preserved. So this is not ischemic for sure. So this is a non-ischemic, right? Just look into the late enhancement. And so this is dilated cardiomyopathy. And this is the most frequent non-ischemic cardiomyopathy. And again here, once you have, when there is the late enhancement present, the presence of late enhancement, so the mortality is significant higher. Another case number 2, like 83 years old, so high-risk patient, hypertension, diabetes, dyslipidemia, and with a chest pain, and the ACGs show ventricular tachycardia and a low ejection fraction. So in a high-risk patient, you should go to the CAT. And as you can see here, the angio is completely normal, or I mean just mild stenosis, no significant stenosis. So it's a high-risk patient with a decrease in the ejection fraction. So here's the MRI. So as you can see here, there is an area of akinesia in the infralateral wall. And also this wall is thin, as you compare to the other one is thin. But we know that this patient has normal coronary. So here is where, again, what is the late enhancement can help. And as you can see here, there is an area of late enhancement here in the mesocardial border. So this is a non-ischemic again. And as you can see here, the endocardial border are preserved. Also the trabeculation, so there is no myocardial infarction that preserves the trabeculation. So this is also non-ischemic heart disease. And in this case is Chagas disease. So it's a pretty rare, uncommon, I know here in Canada, but it's quite frequent in Brazil. And there is one interesting thing that this is a very typical. When you see like all the findings that I show, and with the tiny aneurysm in the apical portion, this is very, very frequent in the Chagas disease. So once a patient that comes from South America maybe, and you see all this, and you see this aneurysm, so you can say, oh, this is a typical case of Chagas disease. There is no other diagnosis. And it's important for all this kind of disease that where you find fibrosis, that you quantify, because we know that the quantification of the amount of fibrosis is now getting important, and there is impact in the treatment and sometimes in what you're going to do for the patient. So another case, it's a 40 years old with a chest pain. A recent CAT showed a 70% stenosis in the RCA. And the patient was treated, was stented, the right coronary artery. But the patient had the chest pain again, and the echo showed a 57% ejection fraction. But because of chest pain, so we decided to do cardiac MRI. And what you can see here is there is a diffuse thickening of the wall. So there is a diffuse hypertrophy. The entire ventricle is hypertrophic. You can see also in the 2-chamber view and in the 4-chamber that the mid cavity is reducing. And when we run the late enhancement, we can see here in the blue, there is late enhancement in the septum. So this is a case of hypertrophic cardiomyopathy. Those are 3 examples of how it could be. This is not the same case. The case that I show is a diffuse hypertrophy of the left ventricle, but It could be like this. It's asymmetric. The other walls are normal, but the septum is thick. It could be in the mid cavity, like here in this case. In the apical portion, and the basal is almost normal. Or it could be just in the apical portion, as you can see here. So, but all those cases are typical of hypertrophic cardiomyopathy. And the importance is because when there is a hypertrophy and there is a fibrosis, so it's related to sudden cardiac death. And now there are some papers coming showing that it depends of the amount of fibrosis. So you will install like a defibrillator in this patient. It's not in the guidelines, but there is a tendency that in the future to decide if you're going to put a defibrillator that is a very expensive device, probably you will need an MRI showing that there is a significant amount of fibrosis. And again, why? Is because when there is more fibrosis, so the patient die more. So we have 7 cases. So I'm in the 4th case. So this is a 62 years old. So heart failure again, class 2. In the echo show like a apical hypertrophy. So you can see here that yes, there is something strange here in the apical portion, but there are other features here. If you look to the atrium, they're too big. They're too big. It's not common when you see apical hypertrophy, like in the previous case that I showed, like you see this kind of dilatation. And there is another funny thing here in the apical portion that you can see the different signal here that is more dark or black. And when we run the delayed enhancement, this is very typical for this pathology that you can see here. Maybe I'm not sure if you're seeing, but there is a normal myocardial here. Then there is the bright, that is the area of fibrosis, that is the delayed enhancement. And then there is the dark one, the black one, that is the thrombus, or sometimes associated with some calcification. So this is the double V sign, that is the fibrosis, and then the thrombus. And this is very typical for the endomyocardial fibrosis. And this is a restrictive cardiomyopathy, and this is very typical finding for this pathology. There are other types of restrictive cardiomyopathies. Amyloidosis, when there is amyloid deposit, so you can see diffuse late enhancement, and is as a restrictive cardiomyopathy, or even sarcoidosis, that you can see some tiny areas, focal areas of late enhancement, with some more extensive areas of late enhancement. And when you suspect of this, and you should look into the lungs and see, like in this case, that is very typical for sarcoidosis, like micronodules in the lungs and enlargement of the lymph nodes. So hemochromatosis is another pathology, is another disease that the MRI now is playing a very important role, mainly in thalassemia and other anemia. So when we do the measurement in the myocardium, in the value that the T2 start is below 20 milliseconds, we know that this is associated with arrhythmias. So sometimes we're going to change the treatment. But for sure, when the T2 star is below 10 milliseconds, so this is, you need really to change the treatment. And the chelating treatment is mandatory for those cases. Otherwise, this patient will go for heart failure. Case number 5 is a patient with 35 years old, atypical chest pain, but she get ST elevation, and echo showed a mild dysfunction, so the patient went to the CAT. So ST elevation with a chest pain, so it's correct to go to the CAT. The CAT was normal, and then after the CAT, so we did the MRI. So this is a T2-weighted sequence, so it's a basic to look into edema. And what we can see here, what is bright in the lateral wall, anterior wall, so you can see that there are some edema in this wall. And the late enhancement also show a mesoepicardial enhancement. So this is not ischemic, right? The endocardial border are preserved. And this is a typical case of myocarditis. So this is a very common, the history helps, and the finding really is to myocarditis. And one thing is, this is the follow-up. So it's very common, the delayed enhancement in the follow-up shrink a little bit. So in the acute phase, the delayed enhancement, and the majority of the time is bigger as compared when you do a follow-up after 3 months or 6 months. Next case is a man, 28 years old with arrhythmias. So you can see in the scene that the right ventricle is dilated. And you can see some areas of dyskinesia here. And always, if you look at here, there is some microaneurysm, some tiny areas of microaneurysm. So also we can see some fat in the right ventricle. And when we do delayed enhancement again, so RV is very big, so it's dilated. And there is diffuse areas of fibrosis in the entire free wall of the right ventricle. So this is, again, is very typical. It is as part of the diagnosis. It is ARVD, so arrhythmogenic right ventricular dysplasia. And MR is part of the diagnosis. So MR is important because for this diagnosis, MR is mandatory. And also, this will drive the patients to put defibrillators. So this is the importance of this exam again for this type of pathology. Last case, 54 years old female with a chest pain. So she went through a lot of stress is related to her relationship, and then had a chest pain. And arrived at the emergency department, and she went for a CAT, and the angiogram was completely normal. So because the echo shows some akinesia in the apical portion, she went to the CAT lab. And then they asked the MRI, and what we can see in the MRI was similar to what they saw in the echo. That is the akinesia of the apical portion. And there is one thing is that is it's the apical ballooning of it's a ballooning of the apical portion because the basal is contracting pretty well, like the basal is contracting pretty well, but the apical portion is akinetic. So no delayed enhancement, so no delayed enhancement with those findings. So this is what we call Takotsubo cardiomyopathy. So this is they call the broken heart syndrome, is related to stress. The majority of the case, sometimes the enzymes increase a little bit. You can see sometimes small areas of focal late enhancement. But what is the typical is this apical ballooning of the portion, and also you will not see late enhancement related to coronary territory. So this is something that is getting much more frequently, and it's related to stress. Last one is left ventricular non-compaction. So every time that you think about left ventricular non-compaction, so you should do a cardiac MRI to confirm. Sometimes for echo, it's difficult to differentiate what is the normal myocardium and what is trabeculation. And we know for the diagnosis is the relation about the area that is compact against the area that is non-compact. And if it's more than 2.3, so this is one of the diagnoses for myocardial non-compaction. Okay, so new technologies. Going to the end, so the new technology, what I'm going to share is there are some new features that help us to perform cardiac MRI. One of these is the CardioLine, what we are using, that it helps us to scan and to run the exam. So from here you can see from the three plane just with just one click. Right after those planes, so you come with this. You come with all this the planes. So the 2-chamber, 4-chamber, short axis, and you can play. You can play with all this, and it helps a lot to preset the image. And that was one thing that was interesting, that we measure the numbers of click that every technician was doing to perform a cardiac MRI. And what is interesting is it's about 14 minutes that was spent in a cardiac MRI just, it's not for run the sequence, it's just to program, just to preset the correct plans and run the exam. It's a lot. So, and sometimes you can run like a knee MRI with 14 minutes, and this is just the time that you spend to prepare the exam. And it's a 200 clicks, 200 mouse click was the median for this exam. Once we change for the cardio line, it drops to 39 clicks, mouse clicks, and we reduce to 4 minutes. And if you are experienced, very experienced technician, so you can drop to 2 minutes. It's about 83% reduction in the time for the preparation for the exam. Like us, we do about 16 cardiac MR a day. For us, it could be something 2 more exams that we can do because we are saving like 10 minutes. We are saving 10 minutes for every cardiac exam. So another thing that is helping is the KT speeder Cine. So what is this? So there are different type of acceleration technique available in the market. And you can speed up to 10 times or a factor of 10 if you want. It depends of your parallel acquisition or your acceleration technique. The Toshiba, the difference is there is no training scan. So the KT sense, the acceleration technique goes directly to the acquisition. There is no training scan. So the regular one, you can speed up to 5. With this one, you can speed up to 8 for the factor. And here is just an example to show with a factor of 4, 5, up to 8. So it's still good image quality. Of course, once you increase your speed factor, so you lost your spatial resolution. But it still is enough image quality for the diagnosis. This is, last month we did a couple of cases to compare those sequences between the regular steady state free precession with the new KT speeder. And in the volunteer, that all the cases that we done, so the correlation was very good. So there is no difference for the measurements between KT speeder and the regular steady state. And here above is the regular steady state, and here is the KT speeder. It's about 13 seconds for each slice in the regular one. And in the KT, 13 seconds, you can run like 3 slices, more or less, like this. And you can see here the image quality is pretty good using acceleration factor. This is a clinical example. So this is with a KT speeder. This is a regular one. So this is, we did a holy heart within just 1 breath hold. It was a long one, it was 20 second breath hold, but we acquired the entire scene for the heart, as compared to this one that is 13 seconds. Of course, the spatial resolution when you run like a single is higher, but I mean, it's not that bad. And you don't need, in the majority of the case, you don't need this spatial resolution to see details in the wall, because this is a scene to quantify the function and the volume measurement. So it's fair enough. And we did, you can speed up your exam. And of course, for normal patients, you can imagine that you do your entire short axis scene is in less than 30 seconds. So you can speed up. And I know that as a director, sometimes cardiac exam take more than an hour. And when you take a look about how much it takes, like a brain or a head or a knee, I mean, it's like you can do like 3 or 4 other exams. And but I think with those techniques, we can speed up the exam. Like in this case, is a patient with arrhythmia, and this is a free breathing. So the patient could not hold the breath. So it's the same patient, and we did free breathing. So you can see here that there is moving as compared to the breath hold. And because there is arrhythmia, sometimes the breath hold sequence is worse as compared to the free breathing or with the factor acceleration, because here you are acquiring a 4 or 5 cardiac cycle. And when we go for the KT speeded, we can run just 1 or 2 cardiac cycles. So you're less artifacts related to the change in the heart rate. Okay, the other important sequence that is new is the 3D delayed enhancement with real-time motion correction. So it's delayed enhancement 3D. I will skip this because I know that there are some physicists in the audience, and if they ask something, I will not be able to answer. So, so let's go for what is the idea of this sequence? So this is, we use a real-time motion correction. So there is a navigator and a respiratory gating. So it's a 2-minute acquisition. And you can do, it's a 3D delayed enhancement. The same image that we used to do with each slice, so you can do as a 3D. And then you can reconstruct from that image the 2-chamber, the 4-chamber, and the short axis. And we can see the area of fibrosis here, here, and here. So you can acquire just one exam, and you can reconstruct in the other plane. So, but this sequence is really not for this kind of analysis. What is good for this sequence is when we work with the electrophysiologists. So we have the 3D, and we can help them to find the areas of fibrosis. And so when they go to the cath lab, the electrophysiologists know exactly where is the area of related to the arrhythmia. So it helps a lot for them to direct where to go, where to put the probe. So I think that this kind of sequence 3D with a good spatial resolution will be very important for this kind of study that is electrophysiology. But of course, if you want, you can do the 3D in the short axis, in the 2-chamber, or in the 4-chamber. It's a breath hold, so it's 24 seconds breath hold, and you can see very nice image quality. As compared to the same case that we did the short axis, I mean, it's pretty similar. Of course, the 2D, there's some, the resolution in some images a little bit better, but I mean, I don't think that this will change your diagnostic. And this is 10 slices, 14 seconds each slice. And finally, going to the end, we work with Toshiba trying to develop the T1 mapping sequence, and I'm glad to say that it is available now. So this is the MOLI. We did many cases, and we know that T1 mapping is the thing before the delayed enhancement. So when there are a big scar of fibrosis, that's easy to find and easy to diagnose. But there is something before the delayed enhancement, that is the T1 mapping sequence. And from this paper from Dr. Lima, there are many diseases like diabetes, hypertension, and all other diseases that the normal value of the myocardium will change. And this is what this sequence will going to happen. And this is the future. And just to show, we did a couple of cases to help to validate the sequence. And normal volunteer, and we are measuring. And disease patient, like with amyloidosis, we see significant changes in the T1 value, like in this case, that the patient has diffuse hypokinesia with thick myocardium. And you can see also that you can see this, it's kind of diffuse, bright, diffuse late enhancement in the entire ventricle. And of course, the T1 mapping was higher. So in summary, we show some case using our 1.5 Tesla and the new features that should help us to perform the cardiac MRI and shrink the time and with a very good image quality. And with that, I would like to say thank you for the opportunity.